Hi, I am Dr. Rashmi Roy, a thyroid surgeon here at the Hospital for Endocrine Surgery. The Hospital for Endocrine Surgery is located in Tampa, Florida, and it's a very special place. It's where we just do endocrine surgery. So we just do thyroid surgery, parathyroid surgery, and adrenal surgery. There are no other surgeries that are done here. So it is actually the first of its kind in the country. You won't find another hospital like us anywhere else. A little bit about myself. I actually am originally from New York. I did my training I went to Johns Hopkins undergrad. I did my surgical training at Columbia University Hospital in New York. And then I went back to Johns Hopkins Hospital to do my endocrine surgery fellowship, where I focused on just endocrine surgery. I had my practice up in Princeton, New Jersey for about 8 years before I came down to Tampa to help build the thyroid program here. Without any further ado, I'm going to start our live Q&A session, and we'll start with the first question. So the first question is, what do lab tests like TSH measure, and why aren't they indicative of thyroid cancer? So normal thyroid function tests that are performed by your primary care doctor or your endocrinologist would be TSH, free T3 levels, and free T4 levels. So those are the way that you monitor the way your thyroid is functioning, meaning your thyroid hormone levels. There is something that's called thyroglobulin. Thyroglobulin is a tumor marker or thyroid cancer marker, but the thyroid itself, it produces thyroglobulin all the time. So the only way to measure thyroglobulin as a thyroid cancer marker is once your thyroid is removed. So a lot of times patients will ask me, my thyroglobulin level is normal or my thyroglobulin level is high, should I be worried? Your thyroglobulin level as a cancer tumor marker that means nothing if your thyroid gland is still in place. It's only used if you've been diagnosed with thyroid cancer, if your whole thyroid gland has been removed, then it's a marker of recurrence. So if your thyroglobulin levels are increased after your thyroid is removed, that's a red flag that you possibly may have a recurrence. But TSH, T3, and T4 are just thyroid hormone markers, so much different than indicators for thyroid cancer. Next question. What's the difference between Graves' disease and Hashimoto's? So Graves' disease and Hashimoto's, they're both autoimmune diseases. So it's both diseases where your body is attacking your thyroid gland, but they produce different symptoms. Okay, so Graves' disease is the most common reason that patients are hyperthyroid or have too much thyroid hormone. And Hashimoto's is the most common reason to be hypothyroid or have low thyroid function. So both autoimmune diseases, but they affect your body differently. So if you're hyperthyroid, you're more likely to have heart palpitations or tremors, sweating, weight loss, insomnia. But if you're hypothyroid, you're more likely to be fatigued, have weight gain, depression, mental fog, things like that. So completely different symptoms. Next question. Would you recommend surgically removing a 6-centimeter goiter? Absolutely. So, there's different reasons to do thyroid surgery. One of the reasons to do thyroid surgery is size of nodules. So if your nodule is greater than, we use the marker of 4 centimeters. It doesn't need to be 4 centimeters on the dot, if it's 3.7 or, you're still in that vicinity. But essentially greater than 4 centimeters, that half of your thyroid gland should be removed. And the reason for that is several things. The first is because biopsies are not as reliable. So if you put a needle into a 4-centimeter nodule and it comes back benign, it has more of a chance of it being incorrect. Okay, so it's what we call a sampling bias. So you take an apple, you put a needle into it. This could be benign, but you could be hiding a thyroid cancer somewhere else. So the biopsies aren't as reliable. So you can fool yourself into thinking that you have a benign nodule when in fact you're hiding a thyroid cancer. So that's one of the reasons to take out half of your thyroid at least if you have a nodule that's over 4 centimeters. Another reason is symptoms. Usually nodules that are 4 centimeters or larger, you can see them, or they're causing what we call compressive symptoms. So trouble swallowing, tightness in your neck, voice changes, a constant clearing of your throat. When you lay down, you kind of feel something, pushing you. Other things that people feel is men, they feel like their shirt sizes are getting bigger. They have to buy bigger shirts, or people are always tugging at their shirt because they feel like something's on your neck. So those are all symptoms of having a large nodule. So yes, if you have a 6 centimeter goiter, you need surgery. Next question. I had my entire thyroid removed last year and am now having trouble getting pregnant. I've read the thyroid is connected to fertility. If I am taking my thyroid hormone medication, should this be a factor affecting my fertility? So I get asked this question all the time. A lot of women are afraid of undergoing thyroid surgery, because they want to get pregnant, they want to have more babies or their first baby, whichever. So yeah, thyroid hormone is very important for fertility, for getting pregnant, but it's important to stay in the normal range. So if you are not in the normal range, if you're hypothyroid or hyperthyroid, then that can affect fertility. But if you are within the normal range, either naturally or with thyroid hormone, then your fertility is not going to be affected. So you don't have to worry about if you need thyroid surgery and half your thyroid needs to be removed, where you need to go on thyroid hormone supplements, or even if your whole thyroid needs to be removed and you're on full dose thyroid hormone replacement. As long as you're taking your medication and as long as you're checking your blood levels and you're within the normal range and you're feeling well, then this will not affect your fertility, so you don't need to worry about not being able to get pregnant. Okay, next question. I had surgery done locally, and unfortunately my vocal cords were damaged. Is this something you can fix if I come see you? So unfortunately, no. Once a nerve has been cut in your prior surgery and you have permanent vocal cord paralysis, this is not something that I can change. It does mean that if you need further thyroid surgery, your thyroid surgery is now much more complex because you need an expert surgeon who's going to make sure that your other nerve to your vocal cord is saved. When we talk and when we breathe, our vocal cords essentially both move. If one cord is paralyzed, you only have the other cord that's allowing you to talk and breathe. If both cords are paralyzed, you cannot breathe on your own. You need a tracheostomy. So you need to make sure that you have an expert surgeon that is doing your next thyroid surgery if you do need one. But unfortunately, if the nerve is cut and it's not fixed during that first surgery, there's nothing that can be done in the operating room during your next surgery. Next question. What is going on with the emergence of these huge goiters all of a sudden? What do you think it's attributed to? I think it's a good question. I don't have a good answer for it, to be honest. I think people are noticing them more because people are becoming more aware of their thyroid gland. Doctors are noticing necks being more full because doctors are looking at the thyroids, whereas opposed to, before they weren't really paying attention to the neck area. So if a patient is coming into the doctor's office and their neck looks full, they're getting more ultrasounds, and then they're getting scans. Also, people are getting scans for other reasons more often. So, there could be a thyroid that's going down into your chest that you can't see, but because they're getting scanned for other reasons, they're noticing they have substernal goiters. It could be diet, it could be environmental, but nothing has really been attributed to it specifically. We do not live in iodine deficient country. Countries in Africa, developing countries, they have low iodine, and that's being attributed to goiters. But really in America, we don't have a low iodine diet. There's really iodine in everything. So I think it's because people are noticing it more and getting more scans that goiters are being found more often. Next question. Why would I have been put on thyroid medication when all my labs were normal? I do have Hashimoto's and a goiter. So sometimes endocrinologists or primary care doctors, they want to try to control your Hashimoto's or try to control the growth of a goiter with a low-dose thyroid hormone. Because the thought is that low-dose thyroid hormone can suppress the thyroid, or it can improve your symptoms from Hashimoto's. So that's most likely why you were put on it. It's either to manage your symptoms of Hashimoto's or to try to contain the goiter. But to be honest, if your labs are normal and you have Hashimoto's, you most likely fall into the category, a low percentage of Hashimoto's patients that actually would benefit from surgery. So if you have Hashimoto's and can't be on medication, surgery is an option for you. If you have a goiter and you're placed on low-dose thyroid hormone medication to try to suppress it, that's actually probably not going to work, and you actually also likely need surgery as well. So just keep that in mind that surgery may be in your future now or in the future. Next question. I attended one of your ultrasound screening events and was fascinated that you're able to tell if something might be cancerous just by what it looks like. What specific characteristics make a nodule suspicious for cancer on ultrasound, and how accurate is this visual assessment? Well, number one, thanks for coming to one of my screening events. So yeah, absolutely. There are specific characteristics on ultrasound that make a nodule look suspicious. The first are the borders, right? The borders of the nodule should be smooth. If they're irregular or kind of jagged looking, then that is a suspicious characteristic. Increased blood flow, or what we call increased vascularity of a thyroid nodule, makes it suspicious. What we call microcalcification, so they just look like white little dots inside the nodule. That's called microcalcification. That is basically a papillary thyroid cancer until proven otherwise. So those are the things. So size, borders, vascularity, having microcalcifications. If something is something that we call hypoechoic, if you see that on your ultrasound report, if it's solid as opposed to cystic. So there's a bunch of things that we look at to rate if your nodule needs further evaluation, such as a biopsy, to see if you have a suspicious thyroid nodule or suspicious suspicious for thyroid cancer. And this visual assessment is very accurate. So ultrasound is the standard of diagnosing or looking at thyroid nodules. So MRI, CT scans, those are not the way that you evaluate thyroid nodules. Ultrasound is the way to do it. So if you feel like you have a thyroid nodule, your next step should be an expert ultrasound. Next question. What are the potential risks if I continue to delay surgery for my goiter? So I ask my goiter patients all the time, why have you waited 15 years to have your thyroid surgery? And I get multiple different types of answers. But basically, if you delay your surgery, number one, it obviously gets bigger. It causes more symptoms. Like the ones I just mentioned, the trouble swallowing, breathing, voice changes. If you delay your surgery, this can go down into your chest further, making the surgery more difficult. So, if you have a big goiter, it's like, what are we waiting for, right? Some patients, when I ask them that question, why'd you wait 15 years? It's because their doctor said, if you're not having symptoms, then don't do anything about it. However, their thyroid is 3-4 times the normal size. So if you have a goiter, you don't want to wait for symptoms, because symptoms with thyroid goiters or symptoms with thyroid cancer, those are symptoms that really affect your quality of life. You don't want to wait till you're having voice changes. You don't want to wait till you're, can't play pickleball because you're gasping for air, or you're short of breath, or, something like that. Be proactive in your care, seek expert evaluation, because you don't want the surgery to become more complicated if we can get it done earlier. Or maybe I just have to remove half your thyroid instead of the whole thyroid. So just, be an advocate for yourself. Okay, next question. I have heard horror stories about thyroid surgery. affecting a patient's breathing, swallowing, or voice. Can you explain how you take precautions to minimize this risk? How often do you see these issues with your patients? So yeah, you're right. We hear the horror stories too of patients coming to see us after they've had a botched surgery. I tell patients all the time, thyroid is in really important real estate. The thyroid lives in your neck, and there are really important structures in your neck around the thyroid gland. Most importantly, the nerves that go to your vocal cords, they travel right underneath the thyroid gland. The parathyroid glands are right next to the thyroid. Those are in charge of your calcium levels, your trachea, esophagus, carotid artery, just really important structures. So, you need an expert doing your operation. So that's the first thing you need to do. I did a video of this on my YouTube channel of things to ask your surgeon of whether of how many they do. So you need to interview your surgeon. The way that we reduce our risk is, number one, we're experts. So we do more thyroid surgeries than anyone in the country. I personally do 600 thyroid surgeries a year. This is all that I do. You need to find a surgeon and that this is all that they do. So by doing this over and over and over again, by being an expert, that's how you minimize the risks. But kind of technically in the operating room, everyone here at the Hospital for Endocrine Surgery at the Thyroid Center operates the same way. We identify the nerves to the vocal cords early on in the operation. We dissect them, we visualize them throughout the whole entire operation and keep them safe. That's the only way to keep them safe. People will tell you that because they use nerve monitors, the nerve is safe. That's false information. The only way to keep your nerve safe is by it being in direct visualization during the whole entire operation. We do use a nerve monitor, but we use it at the end of the surgery to confirm the function of the nerve, to confirm that we have in fact saved them. So the way that you take precaution is by being an expert, is by identifying it early, by preserving it. And our complication rate here, I expect you to wake up with the same voice that you go to sleep with. 99% of our patients do. 1% of our patients will have some temporary hoarseness, even with the most beautiful operation. If that does happen, as long as those nerves are saved, that your voice will return to normal. Now, that voice may take some time to return to normal. It's variable. Could be 2 days, 2 months, even up to a year for your voice to come back to normal. But as long as those nerves were saved, your voice will come back to normal. Next question. Can you explain the accuracy of the different tests used to assess thyroid nodules? For example, fine needle aspiration biopsy, ultrasound, which do you trust most? So we kind of alluded to this before. Ultrasound is the best test for thyroid nodules, and then of course thyroid biopsies. So it's a good question because sometimes, I'll tell patients, I don't even need a biopsy. The way that your thyroid nodule looks on ultrasound is so suspicious that if we get a benign biopsy, I'm not going to believe it. So usually for smaller nodules under 4 centimeters, biopsies are reliable. Benign biopsies are benign, and suspicious biopsies are suspicious that warrant an operation for diagnosis and cure. For me, it's both ultrasound and biopsy that will allow me to make a decision of what you need. But really, ultrasound is, I think, the most important because the way a thyroid nodule looks on ultrasound really is going to sway me into my diagnosis, evaluation, and recommendation. But they're both very accurate, and both are included in an expert evaluation and should be done if you have a thyroid nodule. I was recently diagnosed with a thyroid nodule. How often do thyroid nodules turn out to be cancerous, and what diagnostic tests will I need to determine if mine is? Part B, how likely is it that it's a more aggressive form like medullary thyroid cancer or anaplastic thyroid cancer? Most thyroid nodules are benign. In fact, approximately 90 to 95% of thyroid nodules are benign. Again, you need an ultrasound and you need a biopsy. That's how we're going to determine what your nodule is. The majority of thyroid cancers are papillary thyroid cancer, which is a slow-growing cancer, a very favorable cancer. We're going to cure your thyroid cancer. Our cure rate is 99.8% with papillary thyroid cancers. So yes, it is a thyroid cancer, but it's a manageable one that we'll be able to cure. The likelihood of you having a more aggressive form, medullary thyroid cancers are only 3% of thyroid cancers. And anaplastic thyroid cancer is even more rare than that. Some thyroid surgeons go their whole entire career without seeing an anaplastic thyroid cancer. Now we see a lot of it just because of the nature of who we are here at the Hospital for Endocrine Surgery, but it's super rare. Anaplastic thyroid cancer is super rare. So what you need to not do is go down the rabbit hole of searching anaplastic thyroid cancers on the internet when you find a thyroid nodule, because the likelihood of that happening is really negligible. So just if you have a thyroid nodule, take a deep breath. You just need an ultrasound and a biopsy. If this is a thyroid cancer, it's most likely going to be a papillary thyroid cancer. Next question. If surgery is recommended for my nodule, will you remove the entire thyroid or just the nodule itself? So a lot of people ask this question. The most minimal operation is removing half the thyroid gland. Here at the Hospital for Endocrine Surgery, we like to try to save half the thyroid if we can, because we think that that's better for you. If we can save natural thyroid tissue, natural thyroid hormone, we think that's better for your wellness. But removing just the nodule is not a cancer-appropriate operation. It will not cure a thyroid cancer. So we would never just remove the nodule. It's not a safe operation technically, and it's not an oncologically safe operation. So the most minimal operation is half your thyroid, which we will always try to do if it will be diagnostic and curative. If we need to remove your whole thyroid gland because of other reasons, then we will do so, but we'll always try to save you half. Is it possible for thyroid surgery to affect my hormone levels? Will I need lifelong medication after surgery is completed? So yeah, absolutely. Thyroid surgery will affect your thyroid hormone levels, and the extent of it will be determined with blood work after surgery. So if half your thyroid gland is removed, the hope is that you won't need thyroid medication. So 50% of patients with half of their thyroid intact do not need thyroid hormone replacement. The other 50% do. So if I remove half of your thyroid, I'm not going to start you on medication. You're going to need blood work checked 4 to 6 weeks after surgery, and that will determine if you're good or if you need a supplement. If you do need a supplement, that is lifelong. So that will be a supplement that you will need forever. If your whole thyroid gland is removed, then yes, absolutely. You need lifelong medication. We'll start you on that the day after surgery, and then again, you need blood work checked 4 to 6 weeks later to see if that dose needs to be tweaked at all. But again, that would be a lifelong medication. Next question. If I have autoimmune thyroid disease like Hashimoto's, does this affect the safety or complexity of thyroid surgery? So yes, it does. So Hashimoto's surgeries, or surgeries for Hashimoto's thyroiditis, can be some of the most difficult operations. Graves' patients also, and the reason for that is, chronic Hashimoto's or intense Hashimoto's or Graves'. It's an inflammatory process, so the thyroid can get very inflamed and indurated and scarred down to the surrounding structures. So some of my Hashimoto's surgeries are some of my most difficult, and I always tell patients that, so all those structures that I mentioned, the nerves to the vocal cords, the parathyroid glands, they're all at play. So it does make it a more complex operation, and also, therefore, you need an expert thyroid surgeon doing your surgery if you have Hashimoto's or Graves' disease. Next question. For patients concerned about scarring, what are the best options in terms of surgical approach to reduce visible marks? So there's two approaches to thyroid surgery. One is the traditional approach, where we use a small incision right above your collarbone. So it would be right above your collarbone and a low collar incision in the middle of your neck. We pay a lot of attention to the incision when we're doing this approach. We do a plastic surgery approach, and we do everything we can to limit the scarring. You'll notice your incision for 2 or 3 months, and then it just kind of fades away into a thin line. And we'll teach you how to manage your scar afterwards, things to use on the incision to help it fade away. There's actually a tab on our website that you can look at, and there's a video on there too to see how we design our incision and what patients' scars look like 1 month, 2 months, 3 months after surgery, to give you an idea. The other approach, as opposed to the open traditional approach, is what we call the scarless approach. You do have scars, but it's not scars on your neck. So we offer a robotic approach where we go through your, essentially the armpits, and access the thyroid that way. So instead of having a neck scar, you'll have scars underneath your arms. Next question. Do I need a referral to come to your center? Do you have a waiting list for out-of-town patients? So no, you don't need a referral. If you want to come see us, all you need to do is you find us at thyroidcancer.com. You fill out a new patient form, and then once you fill out that form, then one of the surgeons will actually contact you and go through your history, your reports, and tell you what our recommendation is. There's no wait list. I actually personally call all the out-of-state patients. So you would get a phone call from me if you're out of state. If you're out of town, out of the Tampa area, then one of the other surgeons will give you a call. But the wait list is the same for if you live in Tampa or if you live somewhere else in Florida or around the country, internationally. We're booking about 3 to 4 weeks out, so it's not too long of a wait. And we try to make this process as seamless as possible for you, so that we can evaluate you, diagnose you, and cure you as quickly as possible. Next question. This is one of my favorites. Can anything help a goiter besides surgery? So I have a video about this, about the top 5 myths about goiters. So no, guys. If you have a goiter, you need surgery. Do not rub turmeric on it. Do not rub creams on it. Do not do IV therapy for it. You just need an operation. I'm sorry if that's not what you want to hear, but don't wait because you're scared. Empower yourself with knowledge. Read our website. Watch my YouTube channels. Become comfortable with the fact that you're going to need surgery and find an expert surgeon. Next question. What is the difference between a nodule and a goiter? My ultrasounds show a goiter, but no nodules. I'm so confused. So yeah, that is confusing. So a nodule is a single growth within your thyroid. A goiter is multiple nodules within your goiter or within your thyroid, or a very enlarged thyroid. So for instance, if you have Hashimoto's and you have a big thyroid, you don't have nodules, but someone will call it a Hashimoto's goiter because it's an enlarged thyroid. So basically a goiter is an enlarged thyroid. It can be enlarged for different reasons. One is because you have multiple nodules, and then it's called a multinodule goiter. Another reason could be Hashimoto's or Graves', so then you have a Hashimoto's goiter or a Graves' goiter. So hopefully that helps, and I explained that well enough for you. What does the intake and surgery process look like for a typical patient? So I have a video on this as well on my YouTube channel, so you can actually look at it, and I'll go through the clicks, the tabs that you need to do to become a patient, and I actually have a video of a day in the life of a patient. So I actually walk you through the whole process to get you more comfortable. But essentially, the intake process is like I just said. Go to thyroidcancer.com, click on new patient form, fill everything out. One of us will call you. We'll give you the number to get scheduled, and then our office will help you get scheduled. If you need hotels, we have partner hotels, shuttle services. We try to make it really easy for you. And then the surgery process, you come in and we will do an expert evaluation, which is a high resolution ultrasound. If we need to do a biopsy, we do it right there at that time. We have pathology there at bedside. We have your results in about 20 or 30 minutes. If you need a CAT scan, we have a CAT scan right across the hallway. And then the surgery just takes place down the hallway. So if I'm removing your thyroid gland, it takes me about 30 minutes. If I'm removing your whole thyroid gland, it takes me about an hour. If it's a neck dissection, it's 2.5 to 3 hours. These are all kind of ballpark figures. Obviously, complexity of surgery will make things shorter or longer. But we really try to make this easy for you. We know for the most part, you guys don't want surgery. The hospital is, like I said, a really special place. It's kind of a spa-like environment. Your family and friends who come with you, they get free lunch, free breakfast. They can kind of do work. We have little business sections, so they can get work done while you're having surgery. So look at my YouTube channel for the videos to get yourself acquainted. But that's really the basis of it. Okay, last question. So if my nodule was biopsied as benign, is there any reason to have it biopsied again? Could it become cancerous down the road? So yeah, once you have a thyroid nodule, it just needs to be monitored. It just kind of is what it is. You need to have yearly ultrasounds. If your nodule is the same on your yearly ultrasound, then it doesn't need to be biopsied again. But if it changes in characteristics, such as if it changes in size, or if it gets more suspicious characteristics like the ones that I mentioned earlier on in this Q&A session, like microcalcifications, the irregular borders, vascularity, things like that, then it should be biopsied. For the most part, benign nodules do stay benign, but that's not always the case. So that's why you have to monitor them. So if you've had a benign biopsy, I have patients like this all the time. They've had their nodule for years, it was biopsied benign, and then let's say they skipped 3 or 4 years because they got lost to follow-up, and now their nodule looks suspicious, and it's biopsied, and it's biopsied as suspicious for malignancy, and then it turns out to be a thyroid cancer. So it does happen, so stay on top of it because it is possible. So that is all the questions. Thank you guys for submitting all of them. You can leave comments here so I can answer them in my next Q&A session. I try to do this every 4 to 6 weeks. So I look forward to next time, and I hope you guys have a really good weekend, and I'll see you soon. Bye-bye.